Welcome to the Palm 2 Physical Exam Series. My name is Justin Clutcher. I'm a fourth-year medical student, and we're going to be going through several of the ways we do our physical exams. But to start off with, we want to give you a good look at how to introduce yourselves to your patient. So as always, before any encounter, we're going to start by knocking on the door, waiting for the patient to give us permission to come in. We are then going to wash our hands either at the sink or using the hand sanitizer stations that are typically on the walls. We also want to ensure that our patient is properly draped. At any point you walk in the room and they don't have a drape on, it's typically a good idea to just go ahead and offer it to them. And in the meantime, we also want to introduce ourselves to the patient, being sure to give our titles. For this situation, we'll say medical student. You can say your year if you want. But we also definitely want to address our patients by their last name with as much respect and deference as possible. So let's go through that just now.
Come in.
Mr. Walajahi.
How's it going?
Hi, how are you doing today?
Doing well.
My name's Justin. I'm a fourth-year medical student today, and I'm going to be taking care of you.
Nice to meet you, Justin.
I'm going to wash my hands real quick, but because of the COVID pandemic, we're both masked, and normally I would shake your hand, but it is a pleasure to meet you today.
I get it. It's all right.
How are you doing?
Doing well. How are you?
Doing all right myself. Okay. Are you a little chilly?
It's a little cold.
Yeah, they keep these places really cold. I'm going to go ahead and just put this drape on you, if that's okay.
Yeah, that's perfect. Thank you. I appreciate that.
Awesome. All right. And what can we do for you today? So now that we've finished the history portion of the encounter, we're going to move into the physical exam. And every physical exam typically follows the same pattern of look, listen, feel, or look, auscultate, palpate. And so we're going to go ahead and do our CV exam today, or cardiovascular exam. Okay, so to start off the CV exam, we're going to go ahead and do something called JVP, or jugular venous pressure. To do that, we're first going to have our patient undo his gown. So, Mr. Walajahi, do you mind if I undo your gown?
Go for it.
This is also very important, especially if you have a female patient, to be very conscious of displaying their chest. Okay. So what I'm going to have you start off with to do JVP exam, I'm going to put you in 30 degrees position. So first I'm going to make sure that I pull out the footrest for the patient before I start leaning him back. And I'm going to gently lower him to about 30 degrees. So now that we have him in the 30-degree position and supine, we're able to start doing the JVP exam. So I'm going to have Ahmad take a look to the left. This relaxes his sternocleidomastoid because this is the area that we want to see the pulsations. So Ahmad is young and healthy, and he's probably not going to have very visible JVP, but typically what you would want to do is you want to take your pen light, put it at a transverse angle, and you're just looking for slight pulsations along the external or internal jugular. So the external jugular veins are going to be running this way. They're typically more visible, but they're not as accurate. The internal jugular vein is going to be just medial to that. For Ahmad, because he's young and healthy, his are actually pretty close to the sternal notch, which is normal. So typically what we do is we find the point where we see those pulsations at their apex. Okay, so now that we've found the pulsations of the JVP, we then want to look for something called the manubriosternal notch. So this is going to be just midline in the second intercostal space. So you feel space 1, space 2, and you kind of want to come just to midline, and that point's right here on Ahmad. This is going to be the point that we measure for the JVP to convert it to the central venous pressure, which is the addition of 5 centimeters, or the distance between this point and the right atrium of the heart. We would then take a straight edge of some sort, and then you take your ruler, and you just kind of measure the point just above the sternum. For Ahmad, his is pretty close to 1 centimeter to 2 centimeters, which is normal. Anything over 3 can be considered abnormal. And to fully get the measurement right, you have to also add 5 centimeters because that's about how far the sternum is to the right atrium of the heart. So in someone with congestive heart failure, for example, they might have JVP all the way up their neck, which would then add on 3 or 4 centimeters to that measurement, which could be suggestive of volume overload. Okay, so we're going to start off our CV exam with just simple inspection of our patient. At this point, we're mostly looking for asymmetry, changes in color. We're going to feel for temperatures to see if there's any coolness to his extremities. We're also looking for hair growth or any obvious lesions such as ulcerations or varicosities or edema. So first we'll start off by having our patient remove his gown. Would you mind removing your gown for me?
No, no.
Thank you. And at this point, I'm just visualizing for any symmetry. I don't notice anything apparent at the moment. I next want to be able to definitely look at his hands. So I'll have you pull your hands out of your gown, move your hands out from me, just like this. I'm not noticing anything in particular. I'm going to feel his hands just for warmth. He is warm. He also has good hair growth along his extremities, telling me that he's getting good capillary perfusion. Now I'm going to move and take a look at his legs. Do you mind raising your drape for me just a little bit? Again, we're looking for any obvious asymmetry. If, say, one leg was much bigger than the other, we might be dealing with a DVT or, for example, somebody with lymphedema. If both legs are markedly enlarged, we might be dealing with something like congestive heart failure. We're also looking to see if any of the veins in his legs are swollen or tortuous. That could be an example of varicosities or venous insufficiency. Again, I'm looking for hair growth on his feet. He has good hair as well as warmth. That tells me he's getting good circulation to his feet. One thing we also want to check is for something called clubbing. Typically in individuals who have a lung issue or chronic lung disease of some kind, whether it be restrictive or obstructive, they'll have changes to their fingernails. It's typically visually apparent. Once you've seen it, you can recognize it from a mile away. But one test you can do is to have your patient kind of make almost like a little heart with their fingers. And what you're doing is you're trying to see if there is a space in between their fingers. If not, that's considered clubbing, a sign of clubbing. If you can see the space between their fingers, that's normal. Okay, so now that we've finished the inspection portion of the exam, we're now going to move back up to the chest and begin the palpation portion of the exam. The first thing you're going to palpate for is the point of maximum impulse, which is where the heart is interacting with the chest wall. Typically, you want your patient in the upright position just like this, and you're going to take your hand, be sure to cup your thumb, especially if you're dealing with a female patient, and just gently place your hand in the mid-clavicular line just on the left side. You should feel a pulse at this point. Some individuals, you won't feel it. That's not necessarily abnormal. If you need to, you can have them lie in the lateral decubitus position. We're not going to do that for this video, but and importantly, if you're dealing with a female patient, it is perfectly okay to ask them to hold their breast for you, so you aren't having to be the one doing that. So now we're going to move on to the pulses. There's two regions on the upper extremity that we're going to feel for pulses, and that is the brachial pulse as well as the radial pulse. To find the brachial pulse, we're first going to find the biceps tendon, which is about right here, and then we're going to move just medial to that, and if you put pressure here, you should feel a pulse. I feel Amon's currently right now. The next place we want to check is the radial pulse. Typically, the best way to find that is you find the base of your thumb and go just proximal to that in a little space right here, and you should be able to feel a pulse. Again, it is very important to try to use only your index finger or your middle finger, because if you use your thumb, sometimes you can feel the pulse from your own thumb. So it's always good to use your fingers. Another place you can palpate a pulse, but we typically don't recommend doing it, would be the carotid. Particularly in older individuals, you could dislodge plaques and cause a stroke, and we don't want to do that. So we don't recommend palpating that in clinic. So now that we're on the lower extremity, we're going to again feel for some more pulses. There's two that we're going to be focusing on. That's the posterior tibialis, which is just behind the medial malleolus, as well as the dorsalis pedis, which is typically on the dorsum of the foot, about midway up between the hallucis longus tendon and this extensor tendon. So first we'll feel for the posterior tibialis. You typically just want to, again, it's important to do this bilaterally so you can compare, but you're feeling for the rate, the rhythm, and kind of the strength of the pulsations. These can be particularly difficult to find on more obese patients. Ahmad is, again, generally fit and healthy, so his are pretty palpable. And for the dorsalis pedis, this one can be a little bit tricky to find as well. I typically just kind of start at this region and put light pressure because the skin's rather thin, and eventually you should just kind of feel slight pulsations. Okay. And while we're at this angle, now is a good time to also check for pitting edema. So what you're going to do is you're just going to put light pressure on the shins because the skin there, again, is rather thin and it's right next to the bone. On a normal person or a healthy individual without edema, you should not notice any pitting. The skin should come right back up. That's normal. In a person with heart failure or a DVT or any kind of lymphedema, you'll notice it's almost kind of like a memory foam mattress where the skin just kind of stays in place and it might take some time before it finally starts to refill. That's because there's all that fluid in there that's inside the interstitial space. The last part of the palpation exam we're going to take a look at is capillary refill. Basically, the idea here is we're going to put light pressure on his fingernail, and we're looking to see how quickly the color returns to it. Individuals without any cardiovascular issue or are not dehydrated, have good volume status, are typically going to see a return of color within about 3 seconds. Anything longer than that can be suggestive of poor cardiovascular health, dehydration, low volume status, or blockage somewhere upstream. So what we're going to do just now, I'm going to take my patient's hand and I'm going to just put light pressure on his fingernails. I'm going to put it there for a second and then let go, and you should see the color come back more or less instantaneously. His is very brisk, is what we would write on our note, less than a second. But individuals who have poor cardiovascular health, it might take anywhere from 4, 5, or 6 seconds. So now that we've finished the inspection and palpation portions of our exam, we're now going to move on to auscultation when we finally get to use our stethoscopes. There are 4 regions of the heart that we're particularly listening to, and I'll point them out on Ahmad here. We're first going to start with the aortic region. You want to find the second intercostal space. So here's first, second is about right here, just to the right of the sternum. That's the best place you can hear the aorta, or the aortic valve. If you move just to the left of that, to the left of the sternum, also in the second intercostal space, you're now at the pulmonic region. If you move down 2 spaces to the 4th intercostal space, about right here, you can hear the tricuspid. Again, this is on the left side of the sternum. And finally, if we move into the 5th intercostal space and just to about the mid-clavicular, maybe closer to the mid-axillary line, depending on where the point of maximal impulse is, you will feel the mitral valve, or the site where you listen for the mitral valve. And we'll do all of those using both the diaphragm for high-pitched noises, which are better for listening for murmurs, as well as the bell, which is better for the low-pitched sounds such as the 3rd and 4th heart sound. And we'll do that in the 30-degree patient is kind of lying in the supine region, as well as sitting upright. You can also do it in the left lateral decubitus, as well as leaning forward, but we're not going to do that in this video today. So now I'm going to take a listen to your heart. It's always important whenever you're doing this, especially in an OSCE or CS, to vocalize every heart region that you're listening to, just because the cameras that are monitoring your exam may or may not be able to actually see you. So be sure to emphasize when you're using the diaphragm as well as the bell. So I'm going to start in the 30-degree position, put on my stethoscope, and listen in all 4 regions with the diaphragm first. So now I'm listening to the aorta, the pulmonary valve, tricuspid, and mitral. I'm now going to switch over to the bell and do it all over again. Aorta, pulmonic, tricuspid, and mitral. At this point, I'll now have my patient sit upright. Can I help you up?
Thank you.
And we're going to do the same thing all over again. So again, I'm putting on my stethoscope, switching over to the diaphragm, and just listening in those same 4 places. Aortic, pulmonic, tricuspid, and mitral. Now switching over to my bell and doing just the same thing again. Aortic, pulmonic, tricuspid, and mitral. So that concludes the CV exam. As always, anytime you're doing a physical exam, it's always important to rehydrate and re-gown your patient. Would you mind putting your gown back on and I'll tie it for you?
I don't know.
So the last thing you want to do is walk out of the patient's room, leaving them disrobed. Okay. And at this point is a good time to talk with your patient about what you've seen, what you've discussed, maybe recap what's going on, and maybe give your initial impressions. As always, be sure to ask the patient if they have any questions. Do you have any questions, sir?
I don't think so, no.
Okay. Well, then that finalizes the encounter today. It was a pleasure meeting you.
You as well.
Thank you for coming to see us.